doing?
I'm fine. Can you hear me okay?
Yes, can you hear me?
I can hear you and I can see you. You look beautiful.
You do too.
So it's nice to meet you.
Nice meeting you as well.
So, let's go.
Yeah, let's do it.
Welcome to Black Women's Health Podcast. I'm Dr. Rahman, and I have the esteemed pleasure of speaking with a woman, a physician who specializes in sexual health, Dr. Maria Uloko.
Hello, thank you so much for having me.
It's a pleasure, Doctor. We have lots to talk about. I'm going to kind of give a very brief background based on what I found, and you can kind of fill in the details, okay?
Sounds good.
First of
Sounds
all,
good.
you are a physician.
Yes.
You are a urologist by training.
Yes. And I think all urologists do surgery. It's just depending on what kind of clinical practice that you want to have. We get a lot of training.
All right. Interesting side note, you started medical school at the age of 17?
Yes, I did.
Wow.
I
Wow.
did.
Very, very impressive. Um, and then you did your training, your residency at the University of Minnesota
Yes, I did.
and a fellowship in San Diego Sexual Medicine.
Yes. Yes.
Okay. Um, and now you defined yourself, well, define is not the right word. You give yourself the label of being a sex medicine specialist.
Yes.
Okay.
Yes.
So tell me, what exactly does a sex medicine specialist do?
Yeah. So, one of the common misconceptions, or actually, it's not really a misconception. I am trying to change this. So normally people think of urologists as men's health doctors and surgeons. And so we deal with male sexual health, any penile sexual health, whether it's medical or surgical, we can fix it. And on the flip side, many people think that gynecology also does the same thing when it comes to women's sexual health. But in actuality, the training program and the training model that we have currently for gynecologists does not include sexual health. So, many people with vulvas, many women actually don't have doctors to go to for sexual health. So I'm one of 7 urologists in the world that is able to provide the medical and surgical care of sexual dysfunction for all genders. When we think about men and penises, erectile dysfunction, abnormal curvature of their penis called Peyronie's disease, orgasm dysfunction, pain as well. And on the female side of things, I think about it as chronic pelvic pain, menopause, issues with desire, issues with arousal, issues with orgasm. So I'm able to take care of all genders when it comes to sexual health, which is like one of the most fun things and an absolute superpower. Urology definitely is really good at men's sexual health. That is kind of our bread and butter. We cannot graduate from a training program without, understanding how every procedure that we do, let's say that you have a prostate cancer, let's say that you have prostate cancer, and we remove your prostate, after that, you're going to have sexual dysfunction. And so part of the beauty about urology, what I love about it is that, no matter what issues that we create in prostate cancer, we take out your prostate, we save your life from prostate cancer. We then oftentimes will create sexual dysfunction or even urinary incontinence or leaking of your urine, but then we also fix it. And so that's kind of it's this lovely closed circle.
That's very interesting.
Yep. Yes, my fellowship, the only fellowship in the country that does female sexual health, which we're trying to raise those numbers. Dr. Sarah Signa at GW is starting the first gynecology program that focuses on sexual health, which is amazing. Yeah, it was one of the most eye-opening things because I've been in medicine since I was 17 years old. And I just assumed that I learned everything I need to know as a pelvic surgeon, that, all the organs down there, I knew the names of them, I knew where they were, but I didn't actually know how they functioned. And I didn't realize how important that was until I did my fellowship. And I thought, this is kind of wild that I'd been at that point in medicine for over a decade. And I was like, and I never knew about, hormone regulations and what happens after menopause. And I'm seeing women all the time as even just a general urologist. And so, I have been really surprised by this. My story is actually the story of many physicians, vulvar anatomy, physiology, sexual health, and women's sexual health. And so that's something that I'm really passionate about, closing that gap, training more doctors, doing really, truly changing the curriculum of how we teach doctors about women's health, including menopause care. Because
What made you decide to go into urology?
That's a really fascinating question. It was honestly, I think, just like dumb luck. I like I'm a big believer that I'm a big believer in serendipity. I did not go into um where I am today is just like not where I started in life at all. We started out as, immigrants with very little. And so I'm the first physician in my family. I did not grow up around doctors, so I didn't know, what it even meant to be a doctor. I just knew that's what I wanted to do. And, through a series of fortunate events, I ended up stumbling into urology. I think, I've always had a passion for sex and sexual health. I loved the kidneys. I loved all of that stuff in as I was going through medical school. And I knew my type of personality is I like to see a problem and I like to fix it. I like to talk about it for a little bit and then fix it. And so that was very much aligned with surgery. It's like, hey, there's a problem and you can fix it immediately and get immediate results with surgery. Um, and the surgeons that I dealt with were actually the urologists. I didn't even know that women could be urologists
Mhm.
until I went to a women in surgery conference. And the person that was just the kindest, most well-dressed, like just a relatable human being, um, was a urologist, and her Dr. Hadley Wood at the Cleveland Clinic. And she was the first female urologist that I'd ever met. And I had just finished my surgery rotation, was kind of like, I don't know if I like surgeons. They're kind of mean, at least where I went to medical school. And I met a urologist, and then I decided to take an elective. And I loved it. I was just like, this is it. This is what I want to do. And yeah, it is a very small, like 0.02% of urologists are Black women. So really less than one, like a lot less than 1%, right? And when I started, there was only about 4% of females were urologists, and now it's roughly around 10%. So the numbers are increasing. We still don't have, the appropriate representation that we should. But I've been really impressed by our organization. They are trying to do better. I'm still holding them to high standards, which they're not succeeding yet, but they are doing better. I've been really, especially in the world of women's sexual health. I think because as urologists, we've always centered quality of life in every decision-making plan. We're now seeing, like, even in, bladder cancer, many women suffer from bladder cancer, and the treatments that we have for bladder cancer are pretty intense and invasive and major reconstruction, and take out your bladder, they take out your ovaries, they take out your uterus, they take out all of these really vital, important structures. And so not only are these people dealing with a really heavy diagnosis, they're now having to deal with a fully changed body. And it's interesting for men, we have really solid pathways of what to do with the erectile dysfunction, what to do with the leaking, like all the things. But for women, we actually didn't have anything. It wasn't until, female urologists themselves were like, shouldn't we have a quality of life plan for women who've had bladder cancer too. And, it was a couple of people writing about it. And then now, from several years ago, this was never talked about. I'm now teaching a course at the AUA about sexual health and bladder cancer and after treatment. It's a field that is needs to do better, and it's working towards it, which I'm really excited for. Yeah. Yes, I feel very privileged to be a part of this conversation and be a part of, you know, being considered a leader in that field within urology. And at the same time, also understanding that innovation and collaboration really makes a difference. And so I love collaborating not only with urologists, I love collaborating with gynecologists, with plastic surgeons, like anyone that's a pelvic surgeon within this field. I love collaborating with them and thinking outside of the box and, to answer questions, because I don't think there's any field in medicine that is as ripe for discovery and change than women's sexual health. I love seeing men. I think it's great. It's fun. I love having those conversations with them. But because of the huge disparities and the lack of access to doctors that understand sexual health, my schedule is really booked up with women, not because it's who I like really, I love seeing everyone. That was the whole reason I got my training. It's just that there's just not enough of practitioners that know how to deal with women's sexual health, that it just takes up a lot more of my time. And there's also so much policy and education reform and research that I do around this, because this is such a monumental systematic issue, and being able to treat all genders, I get to see the huge disparities between how men access healthcare and how women access healthcare. It's vastly different. And because I'm able to see those differences, it really does drive my advocacy and my need for change, because it actually makes my job impossible. Taking care of men is very easy, not because their conditions are difficult. It's because insurance is already covered. I know that when I'm prescribing a man a medication, it's going to be covered because urologists have done the hard work of lobbying and getting insurance coverage. I know when I'm prescribing a life-saving medication for a woman, I have to cut coupons. Like I have to literally go through them I'm like, which pharmacy you're going to go to? Okay, this coupon you need to use, this coupon you need to use, because insurances don't cover it, and it's just like, it's these little things that make clinical practice really challenging. And oftentimes I think that's why a lot of people won't do this work, because it's like, well, it's hard to do it in insurance. It's hard to do these things. And I was like, we should not be punishing the patient. We should be, as physicians, advocating for change and figuring out how to make this better. And until I can make that better, and until I can actually go to work, my clinical work, where I see men and I see women, and it's all the same, it's easy. I know when I prescribe a medication, I'm not going to get 19 calls from the pharmacist being like, "Are you sure you want to give them hormones?" I'm like, "Yes." I want that. That's the vision of medical care that I want for everyone. But then the patent expired on Viagra. So now they have all of these generic, once it went generic, it was so much easier, right? And so now a man can get 90 tablets of Viagra for less than $10. Like it's even without insurance. That's without insurance.
Without
And
insurance.
for Yeah, that's without insurance. And many insurance companies, we've deemed erectile dysfunction, we've actually made it an indicator of heart health. So a lot of insurances companies will actually cover it as a medical issue. And so that's what I'm saying. Like when I started my residency in 2015. And that narrative was very true. But within 9 years, we've had reform, right? We've had policy reform, we've had insurance reform. Now that medication is dirt cheap. I remember if you wanted, 10 pills was almost going to be $900 depending on your insurance. now it's like candy, you know, it's an amazing, and I love that.
Is that just for Viagra? Because there are other medications that are Viagra-like
Yep,
that,
yep. So all once the patent expired, all the Viagra, the Cialis, the Levitra, all of those medications went generic, and now they're way more affordable. But many physicians actually don't allow women, we gatekeep it. Yeah, so let's talk about this study because I think this is super important, right? And this is why I think having the ability to take care of all genders matters, right? So when we, so hormones in general, and urologists, we love them. We think they are safe when done safely. We don't have a lot of fear surrounding hormones. And even when we do have fear surrounding hormones, we then do studies to then either support those fears or disband those fears, right? Um, and that's because, and that's where I'm speaking from a place of privilege. So I'm a big believer that research is advocacy. I am a big researcher. I've won international awards. I defined how many nerves are in the human clitoris. I'm still doing a lot of the work on defining the vulvar structures because even though we've been operating on the vulva for hundreds of years, we still don't know a lot of the physiology behind it. It's or what we know is or what we're being taught is wrong. So that's my huge thing is understanding what is actually correct. Because I think there's a lot of misconceptions that then get taught as medical facts, and those misconceptions aren't based on facts. So the WHI, so I say this as when I came into women's health, you know, I already came in with this idea of, you know, hormones are safe when done safely. And so it was interesting though, as soon as I started taking care of women's sexual health, the amount of stories, and I will say there's almost 2,000 stories, I've 2,000 stories of the same conversation that a lot of doctors are scaring women out of even having the choice to get hormones. And a lot of it is based off of the WHI study, which was in 2001. That study was disbanded early because they were having heart issues. Many of the people that were enrolled were having heart issues. They said this is too dangerous. The thing is, then the media took that and said, oh, hormone replacement therapy is dangerous. We should not give it to women. And it led to almost 70% of physicians prior to that study felt comfortable prescribing hormones to less than 10% today. The thing is, that study, when you actually look at it, the average age of the patient in that study was 75 years old. By that time, they've already been through all the bad effects of menopause for at least 20 years. So they didn't even like the whole point of hormone replacement therapy is to support you as you're losing hormones so that you either don't have the symptoms or don't have the negative health effects of lack of hormones. When you're giving someone hormones after all the negative health effects have happened, at that point you're actually they weren't doing anything good. They were actually causing more harm than good. They then reanalyzed that data and showed that if you gave hormones within the first 10 years of menopause or before age 60, it actually prevented against heart disease. It prevented against colon cancer, prevented against endometrial cancer, prevented against osteoporosis, prevented against fractures, which we know is what kills older people of hip fractures. It has almost a 90% mortality, meaning a 90% chance of death with a hip fracture that we could be preventing. It prevents against dementia. It prevents against all of these really, really life-threatening, life-shortening, quality of life, detrimental things. And yet, we still have doctors quoting a study, the wrong information from that study. And so many people come to me saying, oh, my doctor told me it was dangerous, or I read on the internet that it's dangerous. And I'm like, hormones aren't for everyone. I'm 100% in agreement that hormones aren't for everyone. But if we continue this narrative that they're dangerous, and we don't even give people the choice, because that's a story that I would hear a lot, with a lot of people weren't even given the choice to even make that educated decision for themselves, which is something that we don't do on men. And men, we're very much like, hey, here are your stats. Here's what's available to you. Either it's really not safe for you, and we'll tell them that and say, we do not medically feel comfortable giving you hormones, or we'll say, hey, we find it safe. these are the metrics that we have for your safety, and you get to make that choice. Versus a lot of women don't get to make that choice because a lot of their doctors aren't informed about what is currently up to date with hormones.
So are you saying the hormones were not available to women? Because that was our conversation. You were saying men had access, women did not have access, and this lack of
Yeah,
access was because physicians weren't prescribing.
yeah, well, yeah, exactly. I mean, 70 to 10, less than 10%.
So
But then also,
that's not been my experience. That
and
is not
I'm
uh,
grateful that
that
that has not been your experience,
or
but that's,
the doctors that I have been surrounded by, or the recommendations from the American College of OBGYN. Now, what they said, you're right, there was a scare based on that study for women and doctors. And then there was a reevaluation of that study, just like you described. And then the American College of OBGYN came out and said, and they mentioned the time frame, the ages of the women and the
mhm,
optimal time to give it. And they
mhm,
said you should give the lowest dose, the lowest
yep,
effective dose for the shortest period of time. And
yes.
that's been the recommendation.
Yeah, and I like I said, I never said that hormones haven't been available. They're available, but I will tell you the insurance coverage is not great for them, right? Like you can only have a certain type of hormone. A lot of so in California, right? If I were to go in and like I give people the option of all of the hormones that are available that they can take, but then their insurances oftentimes will say, oh, you can't take the patch, you have to take the pill. At that, and we know that the pill has a higher risk of blood clots and cardiac events. And so that's what I mean when I say is that even though we have these formulations, even insurances are not covering the appropriate formulations. And that is a huge barrier of care for people. And yes, ACOG, and this is the thing where I get really frustrated is because ACOG, NAMS, all of these people, all of these big organizations have said, and they have amazing guidelines that give really clear cut directions for people how to prescribe hormones, that it is safe, it is the most effective way to combat hormone replacement or combat the symptoms of menopause. I graduated from medical school at 2015. I wasn't taught anything about menopause. They have really dropped the ball in our curriculum and training doctors on how to treat women outside of reproductive years. And that is something that I think is, oh, it is so, it's doing such a disservice to women because they're the highest advancing group of people that are aging right now. And so there's going to come a time, there's going to come a critical mass where we're going to have a lot of people that are hitting menopause and not enough doctors because we're not being trained on it. And that's the thing I'm scared about. That 70% dropping down to less than 10%, that's data. That's what the national stats are showing. And so my thing is trying to increase that number to get menopause back into our curriculum. Why aren't we learning about this? Women live way more time in menopause than they live in their reproductive years. Yes, so sexual health is very important. I am a big believer that sexual health is important, whether or not you're having sex, right? Sexual health to me is an indicator of overall health. We know that in order to have really good sex, and to be sexually healthy, like we have actual criterias for men with erectile dysfunction. Every man that comes into your office for erectile dysfunction has to be evaluated for cardiac issues because we know that the one of the first signs of cardiac disease in men is erectile dysfunction. So every decade increases 10%. So yeah, it's a really important overall metric of sexual or of all overall health. Yes, and I take that same thinking and mentality into women's sexual health, because the clitoris and the penis are the exact same structure. And when we start seeing sexual dysfunction in women, we should also start thinking about them from a holistic standpoint of, well, what's our cholesterol like? What's our heart health? What's our routine? What's our mental health? What's our spiritual health like? These are really important metrics that I start thinking about, and it's just sex. People like to poo-poo sex, and I'm like, no, it's actually super important, even if you're not having sex, right? So
Can you explain
you
that?
want,
Why is it important if I'm not having sex?
yeah. So this is a fantastic question. So as I said, I'm a translational researcher on vulvar health. When the vulva does not get the healthy hormones that it needs, estrogen, progesterone, and testosterone, which are very important for vulvar health, it actually changes the vulva. The vulva then becomes red, raw, and inflamed. And this inflammation then leads to increases your susceptibility for recurrent UTIs, increases your susceptibility for pain, increases your susceptibility for recurrent vaginal infections, right? It totally changes the flora and totally just changes the architecture and the health of it. And I use the analogy, and so many women will come to me with they'll come with UTIs, they'll come with pelvic pain, they'll come with recurrent vaginal infections. And I'm like, hey, listen, this is actually a symptom of poor vulvar health. The infections, the pain that you're experiencing, this is your vulva screaming out to you, I'm not doing well. I need help. And so many women will be like, well, I'm not having sex, it doesn't really matter. And I'm like, no, 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 it does matter, right? Like I always use the analogy of, let's say that you're not a runner, but what if I told you that if you didn't put lotion on your leg, on one leg every day, your legs would become shriveled up, red, rotten, more likely to get infected and painful? You'd probably put lotion on your leg. And they say, of course, I mean, I'm not a runner, but I want my leg to be healthy. That's the same thing I think about with the vulva. So because we only assign it to sex, when people aren't having sex, they're like, oh, I don't really need to pay attention to it. And I was like, but we do. We want to keep the vulva healthy, because even if you're not having sex, you want a healthy vulva because you want a healthy bladder. So many women, when they hit menopause, perimenopause, they start developing recurrent UTIs over and over and over again. And and if you have healthy anatomy and you're not someone that has these really big risk factors, we can actually prevent that if we just actually prioritize your vulva health and having a really set vulva routine to make sure that your vulva stays healthy until your very last breath on earth. So I never said all, right? I said it's not for everyone, but the thing is, so this is the statement, and I think this is our two different modalities of training. So as a urologist, we know men are going to lose hormone. Men go through menopause. They go through a deficiency and decline in their hormones as well. But you cannot watch so they then have low libido, fatigue. Some men don't have any symptoms, but if you start becoming symptomatic and it's bothering you and it's changing how you live your life and you're miserable, they then have the ability to go to the doctor and get medications to help support them, right? Menopause, by definition, I think I actually like the way you said it. It's physiologically, it's a hormonal deficient state. I don't think philosophically it has to be something that says women are deficient. No, philosophically, no. Physiologically, that is what is happening to the body. And for some people, they can become symptomatic. Actually, 80% of people will develop symptoms with menopause. It all depends on how big your symptoms are. If you're someone that's like, I went through menopause, it was not a big deal, amazing. You don't have to be on hormones. But if you're someone that's suffering, if you're someone that is having issues, then yes, you should be able to go to your doctor and have these conversations. But with the current stats, less than 10% of those doctors are comfortable even having these conversations.
I
And
have
that's
not
the
found that
issue.
to be true.
Yes, but this is important, right? Because
Oh, I think it's,
again,
go ahead, go ahead.
I think this is really important, and I think this is the generational divide because in your generation, and I was even talking to Dr. Sherman Malone, she was like, "We've been prescribing hormones," and I was like, it was just so lovely to talk because I'm a big historian. I love understanding the why things are the way they are. And so, in looking at the trends of hormone replacement therapy, you see that there was a huge spike in the 70s and the 80s, and it wasn't until that 2001 where you see that dive. And so, talking to Dr. Sharon Malone, who happens to be the chief medical officer of Alloy, and Michelle Obama's best friend, she was telling me about, when I trained, it was like, I've been doing this for 30 years. And I was like, that's so, and like we were comparing our experiences, and I was like, Dr. Malone, I didn't hear about menopause, and a lot of the people around me didn't hear about menopause. I was actually in the gynecology department at my academic institution as the menopause person. There was only two of us. And a lot of the residents and fellows that I was teaching had never even had this in their training. And so this is what I'm talking about, is that because of that one study, it took your lived experience and totally turned it upside down to what I'm seeing right now, where we're not getting access to that. And I want to make sure that we are getting access to that important training that we need for every woman.
Okay, I think the training is important for everyone. I think one of the differences that I'm appreciating is that you don't necessarily feel, and I agree, that it should be just in the purview of the OBGYN, that internists
Oh
should
no.
know about it, that urologists should know about it, that's basically anyone that has an encounter with a female in their clinical practice should know about
Yes,
it. And that's way broader than just talking about OBGYN.
absolutely.
I think that's important. Um,
Yes, that's what I want to. I think we have put an unfair burden on the field of gynecology because 50% of the population are women. And we always say, well, I still remember so many, things of, well, that's OB-GYN's problem. I was like, no, they're in our clinic right now. Like, why can't we help them? Why are we designating you know, a thing that's a systemic issue, right? As urologists, menopause affects the bladder. Why are we
that's
saying, oh, it's not our job? Like that's like why are cardiologists? So many women will develop cardiac issues because of after menopause. Why aren't cardiologists being trained on what to look for? Why, oh, osteoporosis, orthopedic surgeons, they could be saving so many lives if they also got trained on menopause, and fractures and all these things. And yet we've just decided that only one specialty could potentially take care of 50% of the population, even though every specialty is interacting with that. That's what I want to change. That is the reform that we desperately need because it affects every system in the body, and yet only one specialty is responsible for the entire body. You all are overworked. Like it's just too much of a burden for one specialty. It just doesn't make any sense.
right, how we look at women's health. And I think that's the big change that I'm seeing. When we look at research in women's health, it's been very limited in the past.
Yes.
Um, when we look at drugs available for women's sexuality, it's been few and far apart compared to what men have.
Men have been the template for healthcare. Um, and I didn't realize it because, I went through medical school and then I joined did a residency in a field predominantly about men, urology, even though it's an interesting thing. Everyone has kidneys, everyone has a bladder, everyone needs a urologist at some point, but it's still highly skewed towards men. Um, and so it wasn't until my fellowship, I learned so much in my fellowship, but I also got to supplement like women's health outside of just, the bladder and the this. I just started thinking about the sexual health too. And I realized that that actually takes a holistic approach. It, like you said, it's a holistic approach of understanding, okay, where are you in your cycle? Where are you in life? What are all these other factors? That's what I love about sexual health, is that there is such a ability to collaborate with other physicians and researchers and thinkers, because it all affects everything. Yeah, I use the coaching analogy quite a bit because I think it makes the most sense. I think a lot of people would come wanting to for me to just fix their life, and I'm like, I can only do so much. I can only make sure that you have, I'm going to use a tennis analogy. I'm going to make sure that you have a tennis racket, and I'm going to make sure that you have tennis shoes, and I'm going to make sure that you have a tennis ball. But the person that's actually going to teach you how to play tennis is most likely going to be you and your partner having discussions, whether you need to bring in a coach, like a sex therapist or a physical therapist, or
It's a nice
there's so
analogy.
many there's so many other like practitioners within the sexual health world that will actually teach you how to play tennis. I think it's a way for me
That's a
to
great
have,
way to explain it. Yeah.
yeah, yeah. Because it helps me kind of have a healthy disconnection, because otherwise they'll just be like, yeah, fix everything. And I'm like, well, I only have this much of skill set and knowledge, and that's what I'm going to give to you. And there are these awesome, amazing practitioners that also have their skill set and knowledge. And together we make your team. Um, and I think having that teamwork approach is really, really lovely. The patient too feel empowered, that they are an active participant in this process. And I really love sexual medicine because my patients are very um they're very empowered. They feel they're gonna I'm gonna give them homework and I know they're gonna do the homework. That's which is really great because I spend a lot of time in primary care and medical school. And so sometimes you tell people like, hey, cut this out of your diet. And diet is hard. It's really, really hard. And so you might not be as motivated because you're not seeing the effects of hypertension right then and there. But typically once you're coming in with your sexual health, you're seeing the effects already and you're pretty highly motivated to fix it. So it's a really fun team approach that way.
I think that when we start to open up the envelope and talk about sexuality, that's going to be very interesting, especially in a day and time when we're still talking about women's reproductive rights and what a woman is able to do with her body and
That
tying that in with sexuality. It's going to make for some really interesting conversations.
that is such a good point. I just got chills. Um, yeah, it is
Yeah.
this has also been an interesting endeavor, and that's just something that I just don't think gynecologists should take the burden solely on, right? Like the fact that your job is heavily regulated. That has never happened in men's health. We don't
Mhm.
have regulations criminalizing you
Mhm.
for doing your job. And as
Mhm.
I've talked to my gynecology colleagues, it's been disheartening, especially in the states where it's banned. It's like, do I save this person's life or do I lose my license? That should not just be gynecology's problem. Like all of us in medicine should be up in arms. We took a oath that says first do no harm. And oh yeah, that is such a good point. I literally have chills.
Yeah. And in that type of environment, can you even picture someone being open and receptive to talk about sexuality? It's like the two don't go together, you know?
Yeah,
So it's going to be just a fascinating um uh, uh, process to see how this all evolves.
yeah. No, I think I one day hope that we can kind of think about it as, and we're so far from it. Like you just brought up such a good point. As when we think about men's sexual health, we think about it as health, not this frivolous thing, not this like
Mm,
bonus. It's part of
mm,
your health care. And I want one day, I don't think it's going to be anytime soon, especially with the political landscape, where we start equating that to your health as well.